Good afternoon. Welcome to another edition of UCSF Department of Medicine Grand Rounds. I'm Bob Wachter. I'm chair of the Department of Medicine here at UCSF. Welcome to our live audience from our department, to our colleagues at UCSF and the UCSF Health System, and our friends at our partner sites in the UCSF Health Network. I see that we already have about 500 or 600 live viewers. And as always, we'll post this video on YouTube later today. I'll announce it on my Twitter feed as well as through more traditional avenues. And the previous grand rounds we've done in this series have received now over 200,000 views, so which is quite gratifying. The ground rules for our live audience are shown here. Put your Zoom window in full screen mode. Type any questions you have in our Q&A button, and we'll try to get to at least some of them during the discussion phases. And the session is being recorded. As I say, will be posted later. None of the speakers have any relevant conflicts of interest. I've been planning these grand rounds now for going on 2 months, and every weekend I sit down and try to find, basically to ask myself if there are any hot and emerging issues, particularly ones in which there are experts here at UCSF who are tackling them and can teach us about them. I can tell you that it is never a struggle to find issues to fill 90 minutes, and today is no exception. Today's grand rounds will be divided into 3 segments of approximately 30 minutes each. We'll go for a total of 90 minutes. In the first, we'll hear from 2 of our intensive care physicians who spent the last month in working in the ICUs in the New York Presbyterian system. Previously in the series, we've heard from a hospitalist who was in New York and some of our palliative care physicians who were doing remote consultation. We've also heard from one of our physicians working for the Navajo Nation. So today's focus, though, will be on what it's like to be in the intensive care units at the most hard-hit area in the United States. The second segment will be a discussion of the UCSF mission and Bolinas community-based studies, which are providing us fascinating information about the prevalence of and risk factors for COVID in 2 very different communities here in the Bay Area. Not only is the information extraordinarily important, these studies are also a model for academic community partnerships. And so our speakers will be 2 academic physician researchers from UCSF, as well as a community member who has helped lead our community partnership group. That will take us to about 1 p.m. And in the last half hour, we'll take a deep dive into the issue of antibody testing, which is complicated, hard to keep up with. We have 2 of our faculty experts to talk about the uses and limitations of testing and some of the challenges with current tests. So the entire session will last for 90 minutes, should be done by 1:30, and let us go ahead and get started with our first 2 speakers and panel discussion. So this is going to be on the experience of working in the ICUs in New York City. Our 2 guests are Michael Peters, Assistant Professor of Medicine in the Division of Pulmonary and Critical Care Medicine here at UCSF Health. Michael's research is focused on identifying treatments to restore airway host defenses in asthma. And Michelle Yu, who's also Assistant Professor of Medicine in our Pulmonary ICU Division. Her research focuses on lung biology and understanding the role of platelets in cystic fibrosis pathogenesis, but that only has a little bit to do with what you've been doing with yourselves for the last month, as both of you were among the volunteers who went to New York and have been working at New York Presbyterian for the last month. So thank you for joining us, and thank you for what you have done. First of all, tell us a little bit about your motivation, what made you want to do this. Go ahead, Mike.
Yeah, I think it's pretty obvious maybe what our motivation is. I mean, we're critical care physicians, and here in San Francisco, we've been fortunate to have a relatively small sample size of COVID patients in the community, and we haven't been treating really a large number. And obviously what's gone on in New York has been pretty pronounced and dramatic. And so I think many of us, almost all of us, had some desire to go help out our colleagues that were in New York. And Michelle and I and Maya from our division were we're lucky enough to kind of participate and be able to fill that void.
Great. Michelle, anything to add?
I would say, if anything, I think we were demonstrating the feasibility of a mission like this. And I know that other centers would have done the same if it had been San Francisco as the nation's pandemic epicenter. And the nice thing is that as an academic institution, we do have, we're stacked fairly deep with physicians, clinicians, scientists, and educators who have protected time for research. Both Michael and myself do, and Maya and several others who went. And so in some ways, we're at the exact population or demographic of healthcare workers that need to go because we have that bandwidth.
And Michelle, how did fear factor into this? There's a piece of this that does feel like running into a fire. And we've heard about healthcare workers who have died of COVID, particularly in New York. So how did you process that?
I don't think that was a factor. I think you know very well, Bob, I was probably one of the first people kind of chomping at the bit to go and asking permission from a lot of people. It was a no-brainer. And in part, I'm lucky in that I'm fairly, you know, I have parents that I care for, but even now I can't see them in person. I'm more of a danger to them. So I am fairly mobile in that it was really just my lab that was shut down that I was leaving behind, and I didn't really think twice about it.
Okay. Mike, any other thoughts?
No, not really. I mean, I think fear is, you know, it's natural in these scenarios, but I think most of us, it's kind of what we do.
Yeah.
So this is kind of just the job, right?
Yeah. So you got there about a month ago, and things had already been in some ways apocalyptic there for a month or so. So you must have had some expectations of what you were going to see. You've watched the news and read things. Tell me about the expectations, and then tell me about what it felt like when you finally got there and saw the scene. Go ahead, Michael.
Yeah, it's, you know, it's funny because I did this in my own head, right? Of course, going through the moments was what was I anticipating, and then when we were there was my anticipations, like what was the reality. And you know, I expected to go into a pretty chaotic scene, and yet when we got there, it was probably more chaotic and more overwhelming than maybe I expected. And it was weird to experience that because it wasn't, I thought I had prepared myself for kind of, you know, what we were expecting. We were all expecting this, and yet still, it was still somewhat shocking.
So in what way, what did you see in terms of the chaos?
The magnitude of pain and illness and sickness was way beyond anything that you would kind of anticipate, I feel. There's just an incredible amount of very sick and dying patients all around you. And, you know, we're critical care physicians. This is what we do. But the scale was just so dramatic, and the overwhelming of the infrastructure that was, at least in Queens, was really shocking. And how that could happen in an American institution, New York City, a relatively, you know, well-established city, obviously.
Yeah.
It was really surprising that it would be at the scale and magnitude that it was.
Yeah. And maybe paint a little bit of a picture. So you walk into the ICU, and if you walked into the ICU 100 feet away from where I'm sitting now, you would see patients in single rooms, some of them on a ventilator. People would be standing in the hallway, maybe a nurse would be in the room, and pretty calm, despite the fact that what's going on is still pretty crazy, but pretty calm, and we've been doing this forever. What was the scene like when you walked in there?
Yeah, so first off, it's not an ICU. Bam. So I walked into a PACU that had been repurposed.
We have some non-medical listeners. What to tell
Yeah,
them
so
what
that's the post-op care unit of a surgery ward. So it's really just patients lined up in, you know, separated by, you know, curtains. I was thrown in right in the spot in the mix. I was the attending, taking care of 15 extremely sick patients. There was another attending, quote unquote, who was a fellow who was taking care of the other 15 patients. I had an ortho resident. I had an interventional radiology resident and 2 nurses, and that was the team. I had never been in this hospital before. They were all the sickest patients I've ever taken care of. About half of them were on LTV vents. Those are the portable ventilators. The other half were on trilogy vents.
So meaning that they'd run out of their sort of regular ventilators and they're using.
Yeah, and I ran my own drips. I created my own bags. We coded our own patients. The first time, you know, we were rounding, I realized everyone's height was wrong. We didn't have a tape measure, so I got the ortho resident to get an NG tube to measure everyone's height. This is how we're operating. it was, drips, drugs, everything is all scattered all over the place. And you're literally struggling to stay above the water, really. And it's a challenging situation to do that in.
Yep.
Not to mention the overall fear of just, at that point, then there's some degree of fear of, oh my God, am I hurting people and I'm making them better, and what to do about all of that. And obviously treating a disease you have no idea how to treat.
Yep.
And so it's a pretty overwhelming experience to just be put into it initially. At least that's the way I felt.
When you say, am I hurting people, what, just because the resources are so few and the people you're around
it's because you really don't know what the right thing to do is. I think, as a medical doctor, we're all trained to follow, I'm attending, I've been doing this a relatively long time now. And I feel like I have pretty good expertise in ARDS and management, but I don't have expertise treating COVID.
Yeah.
And I certainly don't have expertise treating them in those scenarios. And so it's a skill set that you just are trying to learn on the fly, and trying to keep order. I think was also really important, to try and maintain some kind of structure to make sure that we can at least do the things that we know are good and beneficial, and try and focus on that, while also just trying to keep everyone protected and everyone safe. And when I say protect and safe, I also mean the patients, and making sure that, we're not putting in the wrong drips or, doing all sorts of things that, you might,
so standard patient safety issues, as opposed to sort of
right.
what we think of PPE and all that, but just making sure we're not giving them the wrong drug.
Right. That's, that all that, like, we're pulling drugs out of the pharmacy. There's no pharmacy. There's no Pyxis. The nurses are 2 nurses for, 14 patients is not the ICU that we're used to.
We're used to essentially one-on-one for a patient that's sick. And
right.
there it's 1-on-7, basically, it sounds like.
Yeah. And we're all doing each other's job. I'm managing the vent, changing the vents, changing the drips. The residents are doing that. And everyone's doing, to be fair, it's a combination of fear and sadness to some extent, but also coupled with incredible inspiration. Yeah. The workers from Queens in particular, unbelievable effort from them to be doing it longer than we were. Really outstanding and really impressive work.
Yeah, thanks. Michelle, take us through, sort of maybe add to what Michael's outlined in terms of what surprised you when you got there, and sort of what your learning curve was as you began settling in.
When I arrived, it was in a neuro step-down unit. I was lucky enough to have what was a fairly functional, could be converted into an ICU. There were big glass sliding doors that allowed you in and out of the rooms. Of course, that means that nothing is truly negative pressure. They had the scrubber machines in there to convert the few actual negative pressure rooms. Similar policies in places to UCSF as to what therapies, something as minimal as high flow or nebulizers, was considered aerosolizing, and there was a certain amount of fear of exposure there. My staff was all neuro ICU, or a lot of actual outpatient nurses that were pulled into this role. I had fellows that were pulled in off of their ACGME fellowship years to serve as medical residents, who all rose to the challenge. And actually, one of them was a GI fellow, so we ended up pegging most of my trach patients kind of like, then and there. Was just everyone rising to the best of their ability in really beautiful ways. And the other fellow was a HEMONC fellow who was pulled into resident position. I had a team of neuro PAs, which, I do most of my attending as a junior ICU faculty member in the neuro ICUs in San Francisco. So it was in some ways just like home. Mm-hmm. A lot of what Michael mentioned is the resource limitations we were protected from at Cornell. But I think our role in that, in the pandemic, was thus a little bit different from Queens. We served more to receive patients from Lower Manhattan and from the boroughs. I think we could have done more, but that's always what I push for, is to do more. But I do understand now that there was like more of a global role that everyone is trying to balance in terms of what the roles that the hospitals have to play. I think I was given this incredible opportunity to actually have enough resources to flex my ability as an ICU provider. So really what I aimed to do in the beginning was get people out of like these heavy sedation regimens that basically left them in versed comas, cross titrate on to oral methadone and oral clonidine, get them off of versed, more on propofol and dexmedetomidine. And eventually, I think the biggest lesson that I learned was the mental status. Like without a mental status, you really have nothing left. And a lot of patients, having been intubated for so long or been in OR situations where it was very dark and like a makeshift ICU, they suffered from a lot of delirium. So that was like a major goal. But we ended up extubating 5 patients in the first 2 days that I was on service, and I felt, great about this. But as Michael alluded to, it very much is a learning curve as to treating a disease you have really no idea how to treat. I was humbled. 2 days later, had to reintubate 2 of those people, and we, came up against all these interesting medical challenges that we didn't expect. Some of them lack of physical therapy, some of them lack of respiratory care to provide, even like a chest vest or something that would allow mucolytic therapy. But some of them just like profound weakness or stridor. There were a lot of ET tube malfunctioning situations that happened, and every time you do a tube exchange, you would like take 5 steps back because you'd completely de-recruit the lungs. So a lot of like ICU problems that we did not anticipate. Also, I would say that we were giving a lot of study drugs there, and I know this is a hot topic, but tocilizumab, sirolimus, sometimes just straight up steroids at this empiric 0.5 cc's per kilo BID for 5 days, and we had a lot of line infections. We had more line infections and VAPs and urinary tract infections than I've ever seen in an ICU, and that might have also been in part because we had so many nurses that cross-trained and didn't know to do chlorhexidine baths and like some things that we take for granted in an ICU, So I am very grateful for all of the learning that I got to do. Every little bit of ICU care really, really matters. And I'll just close this by saying, like, really the thing that struck me as the most impressive was the local heroes there. Everybody from the janitorial staff to the mid-levels to the nurses, the bedside nurses were just absolutely incredible and pulled together as a team. And I got to stay on the same unit for an entire month. So a lot of what I was doing was teaching them to build a foundation for, when we had to leave. They all have this incredible knowledge base now as to how to manage ventilators and ARDS and one approach to tackling COVID.
So maybe back to both of you. I'm going to start with Michelle. That you both mentioned your own personal learning curve, that you're both incredibly well-trained critical care physicians, and you came there as novices in COVID. And you were thrown into an environment where you were surrounded by people who had graduate degrees in COVID because they've been doing it for 6 weeks. So what were a couple of things you learned from, I assume you sort of asked them, like, tell me, like, how do you do this thing? In terms of drugs or proning or whatever it is, tricks of the trade. What are 1 or 2 things that they taught you when you got there?
Proning, I will speak on that because I think that is one of the more heavily evidence-based practices, and it's incredibly easy to do with just the right team of people. And that's really all we would do is we would take the patient, we had fitted sheets on the bed, so we kind of like bundle them up in this fitted sheet and then flip them with a team of 5 or 6 people, and it was all hands on deck, whoever was around. There was a proning team if you needed to have extra hands. But that was very feasible to do, and we did 12 hours on at a time, and then resupine the patients, and there was an incredible response to that. So that's one. I'd say there was a lot of empiric anticoagulation, which I have a lot of mixed feelings about. I think almost every provider had at least one case of an intracranial hemorrhage that happened on empiric therapeutic anticoagulation.
So was there rigid guidelines about whether you do or don't anticoagulate people? It was kind of left up to everybody's individual thoughts.
It was left up to people, but Michael can speak on this more. We saw very high D-dimer levels in Queens. They were much higher than in Cornell, but I also had complications of like massive saddle PEs in a patient 40-something. Only medical condition was asthma, and she had been on prophylactic enoxaparin, and so we saw those cases too, and I did see her D-dimer skyrocket then. So it's not, there was some evidence basis, at least anecdotally, to do that.
All right. Michael, what were a couple of things you learned from your seniors when you got there?
Yeah, I think humility was what I learned fundamentally. If I thought I learned anything, I clearly didn't learn it immediately the next day. That I think all of us were really struggling with what to do. And I think personally, I think anyone who thinks very confidently that they know what the right thing to do is in these scenarios is probably not appreciating how complicated these decisions were. And so it was necessary to kind of we all kind of grouped together and, made decisions. And I'm not entirely sure all of them are right. I'm pretty sure that many of them were wrong, actually. But they were the best, that we were making at the time, and that's really all we could do. In regards to anticoagulation, we pushed some TPA at some times. It seemed to work. Sometimes it didn't. There was a lot of death, and I don't know if I have too much scientific to take away of what the right thing to do is, because I think that would be wrong, because I don't know what the right thing to do is. And I think a lot of people were struggling with that, and that was very profound. It's a great way to crush your ego.
Yeah, I can imagine. Yeah, no, we all are learning about this thing every day, and what you thought you knew yesterday turns out to be pretty uncertain.
Yeah.
Talk a little bit about the mortality, both talk about the rates, and I'd be interested in, the rates that we're seeing here at UCSF are quite low compared to what's reported from New York. And so A, was that your experience? And B, how do you explain it? Is just the fact that the system is so overwhelmed?
This is really hard. I have my opinion. The rates that happen in New York, in Italy, and other places that are overwhelmed, the disease is really bad. Fundamentally, this is why we're all on lockdown.
Yeah.
And epidemiologically, in a place that has been hit as hard as New York, and has so many severe sick patients, the patients that are the sickest are much sicker than the patients that you're seeing that I think we're seeing at UCSF. Just kind of fundamentally, we had an ICU of 100 patients and scattered in an ICU setting. They were intubated. We had 30 patients that were intubated on the floors. There were patients on the floors. I think most of them would probably be in our ICU. And so there's a massive skewing of the severity of illness that I think occurs in these settings that is different than, when you have 30 patients total in, San Francisco.
Yeah. And
so that skews the numbers. In addition, we just talked about all the things, patient safety and other things that certainly probably play an impact. I don't know what the impact is. It's probably something. It's not everything though. And so putting a percentage on it is hard, but it's bad. It's a bad disease.
Yeah. Yeah. We need to finish up in a couple of minutes. Michelle, are there a couple of things that you're going to take with you for the rest of your life from this experience?
The humility lesson is a big one. I think when it comes to a new disease like this, there are lessons that we will learn. For example, the compliance of the lungs may not be as affected by this type of viral pneumonia as others, but it doesn't mean that your algorithms for treating your EDS are any different. And I think one big lesson was to remember the critical care practices that and to return to what's evidence-based. I found myself doing a lot of things towards the end, learning from the people who had, as you said, had like the long game experience of COVID, trying things out. But at the end of the day, I kept asking myself, am I causing this patient more harm than good? And I would say it's also very humbling to know that as much as we try, like there's only so much the medical profession can do, because there are limitations, resource limitations, personnel limitations that we don't have a lot of control over. And, just one small example, I do know that we have to wrap up, but like we would receive patients from the outer boroughs that had fentanyl patches on as their only means of analgesia, no sedation because the hospitals had run out of drips, and they were paralyzed because that was the safest way to transport them. Yeah. And why couldn't the hospitals send drips over to their sister hospitals in the boroughs? Why couldn't we accept more patients? You brought up the question about mortality, and I know our numbers in Queens were in the teens, like maybe 10% the first week I was there, and that was kind of early on when they had just opened the ICU, so the timing
10%,
of it.
10% survival or mortality?
Mortality of ICU patients, and that number I think is falsely low for two reasons. One, it was earlier in the actual opening of our makeshift ICUs, and two, this may be true or not, but I think that centers like Cornell were accepting patients who were the most savable in some ways. So not necessarily the sickest, but maybe the most stable for transfer. And I know that a lot of patients that were out in the boroughs never got the chance to come for higher level care. And that's a message that I've stressed in our calls before, Bob, like when we were doing our check-ins, that the role of these centers, just like the role of UCSF, is to send help out to those pandemic epicenters. The role of those academic centers that have a lot of resources to take patients that need to be cared for without the fear of, am I going to stack up hundreds of these ventilated trach patients and have to create like an LTAC out of several of my hospital floors? It really is, we cannot put a price on human life right now. Like, we have to do everything we can to save lives that can be saved.
Right. Thank you. Michael, I'll finish up with you. What are the things that you're going to take away?
Just, it's hard, and I think the thing I take away is just some component of inspiration. You know, I think everyone in New York, at least that I got in contact with, really was very inspiring, and there was a lot of good that was being done, actually, and that's something that I think sometimes gets lost in this, is, you know, behind the closed doors where no one sees anything that's going on, there's a lot of good that's actually happening, and a lot of people are really putting their neck out, literally and physically and figuratively, to try and help and ease pain, and ease suffering, and they're doing it really because they care. And so it's a great message, and one that, you know, that fills you at least with a little bit of warmth in a troubling time.
Well, I feel the same way about both of you and your colleagues. It's completely inspiring and sobering, and thank you for doing that, really, on behalf of all of us, those of us who were back here, are just admiring what you did and what you've learned, and you will teach us some of the lessons that you learned there, including both the inspiration and the humility. So thanks so much for coming on today, and stay well.
Thanks, Bob.
All right.
Thanks for having us.
A pleasure. Let us switch gears to the next group, and we're going to now focus on the UCSF Mission and Bolinas community studies. We have three speakers who will join us. One is Diane Havlir, who's professor of medicine and chief of our division of HIV, infectious disease, and global medicine at Zuckerberg San Francisco General Hospital. Diane is a world-renowned leader in HIV clinical care and research, and she has been partnering with the San Francisco community to provide COVID testing to residents of the Mission and Bolinas to help us inform our response to the epidemic. So I'll actually go ahead and introduce all three speakers for now, but we'll start with Diane. The next speaker will be John Jacobo. John is the Latino Task Force Chair of the UCSF Unidos El Salud Study Committee. He's also Vice President of Calle 24 Latino Cultural District. He's a native of the Mission District here in San Francisco and a leader in the fight for low income and affordable housing. Brian Greenhouse will be the third speaker. Brian is Associate Professor of Medicine in the HIV, Infectious Disease, and Global Medicine Division that Diane runs. His research focuses on developing new tools to better measure malaria transmission, but like so many of us, he has moved into another interesting infectious disease, so he's devoting a lot of his attention to COVID now. And he is working with Diane and leading the UCSF Mission and Bolinas community study with a particular focus on Bolinas. So we're going to start out with Diane, and then we will move on to John and Brian. So Diane, thanks very much.
Great, thanks very much, Bob. An opportunity to share our preliminary results of these two studies. Next slide, please. Great. So COVID, as we know, is caused by a highly transmissible virus that's infected millions of people over the last couple of months. What we just heard was that this is a serious disease that causes great morbidity and mortality and suffering. And that's the bad news. I think that the good news is that that represents, fortunately, a small proportion, a couple of % of all the people who get infected with this virus. And given that, and we've talked about this early in Grand Rounds, that this virus has high levels from the onset of infection, even before people have symptoms, and some people never have symptoms, that until we get a vaccine and better treatment, testing and responding to persons in the community before they are hospitalized is one way that we can try to accelerate epidemic control. Now, we know that early on, testing was focused on symptomatic persons, in fact, highly symptomatic persons that had indications to get into the hospital. Well, fortunately, that's changing. What we wanted to do was to understand this orange part of the pyramid. We wanted to understand COVID-19 transmission dynamics at the community level, and you'll hear about today two communities that we are studying. Next slide. So the COVID-19 test and response study or the Unidos en Salud United in Health study, was motivated by what we were seeing in terms of the proportion of Latinx people, the disproportionate number of Latinx people getting COVID infections in our city, and really directly at Zuckerberg San Francisco Hospital, the high percentage of infections that were occurring among the Latinx community. And here you can see 84% of the hospitalized cases Latinx, and this compares to, just for everything else, somewhere in the 20 to 30% range. These disparities are continuing. Things are getting better, but persisting during shelter in place. And of course, we need data to inform how we're going to do this community level response. Next slide. So the mission projects, Unidos en Salud, we chose a census tract in the Mission District, which is the highest census, highest density living census tract in the Mission District. It's 58% Latinx and 34% household income at the lowest levels. Next slide. So we did this study 6 weeks into shelter in place, and our study objectives were reach, test, and respond. We wanted to inform and mobilize a population that wasn't being reached by current testing and care systems. We wanted to test to look for active infections with PCR and prior infections with antibodies by testing all persons regardless of their symptoms. And testing is certainly not enough. We're not just going to test people and not offer some way to improve their condition. So we developed a novel community-based test to care program that we'll tell you a little bit more about. Now, these are just the preliminary results of the PCR only, which we presented to the community. Antibody testing and molecular epidemiologic studies are in progress, and we'll be following this cohort hopefully over time as shelter-in-place restrictions are lifted. Next slide. The foundation of any study ever done in the community are the partnerships that one has. This study was done for the community, with the community at the center. And really critical to this partnership is the Latino COVID-19 Task Force, which were the first group that we reached out when we wanted to talk about whether this was something that we had in common we wanted to do together. And also Hillary Ronan, who's a supervisor of the Mission District from the very start. We also forged partnerships with the Office of the Mayor, the Health Department. We got to know a lot about Parks and Rec and the school board because we did our testing at 2 school sites and 2 parks, which of course were completely closed down. Many individuals at UCSF, at ZSFG, the Chan Zuckerberg BioHub, and UC Clinical Labs was absolutely critical in doing high volume rapid testing for people who participated in this program. During the course of the study, we recruited and trained 450 medical and community volunteers. I'm sure there's some on this call here, and it was really just an amazing, generous contribution of community members, really from all walks of life. And here's just some pictures on the top showing one of our sites at Flynn Elementary School, which is just right off of Cesar Chavez. And then here you can see the Brava Theater, which is in the Mission, was donated as headquarters for us. And this is a Latino task force. And you can see John Jacobo. And I think I'm going to hand it over to Bob, who's going to ask John a couple of questions about how the task force got involved.
Thank you, Diane. Alyssa, I need to start my video. There we go. Thank you. So yeah, John, if you could come on, just on with your video and audio. Hi, how are you? Yeah, perfect. Thanks. So tell us about how you first heard about the study, and as you thought about it, what seemed like a good idea about doing this with these partners.
Yeah, well, first, thank you guys for having me. It's been an honor and a privilege to be able to work with Dr. Havlir and many others through this study. So the Latino Task Force was something that came together through community. Clearly, COVID, we knew was going to impact the Latino community here in the Mission District and citywide. But what we had anticipated and what we were looking at was the economic reality that we all knew was coming with the shelter in place and people being out of work, the inability to maybe get food. And so the task force was created to try to meet the needs of our community through partnership with CBOs, et cetera. What we unfortunately maybe should have looked at a little better and did not anticipate was the disproportionate reality that exists with the health disparities that are coupled with many of our, working class communities of color. And so I would say maybe 4 weeks into lockdown, 5 weeks, we were approached by Diane Jones, a retired nurse that worked at Ward 86, and Dr. Havlir to begin the discussions about a potential study. And what I would say is that maybe the week prior or a week and a half prior to that, we had been looking at trying to get demographic information here in San Francisco because The Hill had broken an article, as well as the New York Times, highlighting the disparities in New York, in the Bronx, et cetera. And anecdotally, many of us here in the community could tell that there was definitely something going on. And, I would say that with working class communities and communities of color, there tends to be distrust of large institutions because the historic reality is that large institutions have not always had the best partnerships with communities. And so there was a deep and thorough conversation about what this meant. And one of the things that came out of the Latino Task Force's perspective was that this had to truly be a partnership, a building together, and not something that would be dictated and then, us use as a novelty to say, oh, look what we did. And what I can tell you and report to you and confirm with you today is that that is exactly what did happen. There was true partnership, and from Dr. Havlir to the rest of the UCSF team, it was always diverting to us as the experts of our realm, which is community and the engagement side of it. And that, I think, was very instrumental in building the trust on the front end and, having the level of success that we've been able to have.
That's great. That's wonderful to hear. I imagine there must have been some fear or distrust, maybe not so much, you've already mentioned the relationship with a big academic institution, but just the issue of somebody coming into my neighborhood and testing everybody.
Yeah.
How did people feel about that, and how did you assuage people's fears about what might happen with the results?
And this is where I think the community partnership piece is most important, because I've used this analogy 100 times now, but it was truly building a plane and flying it at once. We're advocates. The folks with this task force are all, I'm born here a couple blocks from where I live, and I actually live in the census tract that we examine, but many of us have been doing advocacy and organizing for, some for decades, many more. So, we understand our community, but adapting to what is being brought back from the field when people are door knocking and interacting was the important piece. There was the generic questions of, could this potentially impact my status if maybe I'm not documented? Who gets this information? What are they going to do with it? Is it a study just to study us, and then they're going to try to use vaccines on us? Like, there's a lot of questions that I think, again, come out of this unfortunate historic relationship, and not unique to UCSF, but just in general, of mistrust of things not being done appropriately. And so I think our ability to know our community and provide the correct information through messaging was key in overcoming it. But the fact is, yeah, a lot of people were unsure that they wanted to come out and get tested. We had just got done with a 4-week campaign of telling people to stay inside. I mean, we were on the radio, we were on the streets, and then we had people tell us, like, dude, you've been telling me for weeks to stay inside, and now you're telling me to come out. Like, think of
Right.
There's obviously things that we had to get through, but I think we were successful because, the folks that were helping run the community engagement side really knew the community at its core.
Right. Well, that's wonderful to hear. All right, let's hear a little bit more about the results from Diane, and then I'll bring it back on at the end.
Great, thanks, John. Okay, so next slide, please. So let's take a look at the results. So first of all, it was very clear that there's a high demand for, I would say, easy access testing in the community. And here you can see the tents. We did testing all outdoors, and in 4 days, we tested over 4,000 individuals. At the time we started the study, there were about 14,000 people who had any test results in San Francisco. So you can see this was a large proportion that we were adding to this number. Next slide. So who did we reach for the COVID testing? Here's our total number of 4,160. And among those, the folks who lived and may have worked or may not in the census district, plus the people who were working in this census tract during the time of the study, we reached 2,959. Now, there was, during the course of the study, great demand on our website. We did registration through our website, and we had many, many chats constantly ongoing on the website. People said, I just live across the street. Why can't I get tested? What we said is we possibly can. We'll let you test on the last day. And so on the last day, we tested an additional 800 community residents just outside of the census district. We also offered testing for anybody remotely related to the study volunteering that wanted to get tested. So that was another 401. So among the residents and workers, about 55% were male, 44% were Latinx, 38% white, and 11% Asian. Next slide. So here's the top line descriptive results in this census tract among the individuals that we tested. In this community, there were 2.1% of persons, 62 persons who were PCR positive. And when we divide this into two mutually exclusive groups, those who didn't live in the census tract but work there, the prevalence was 6.1%, and those who live there, it was 1.4%. And these folks who we tested on the last day, this is kind of super interesting, the expanded area prevalence, actually the residents, the prevalence was also identical at 1.4%. Next slide. So one of the questions in our questionnaire, we were really interested to understand how was shelter in place affecting persons 6 weeks into it. And this was one of the questions we asked, and there was just a really dramatic difference among the people who ended up being PCR positive versus, in this graph we show on the right side in this table, everyone who was tested. So what you can see among the folks who are actively infected with PCR, 90% answered this question that during shelter in place that they cannot work from home. And that was compared to 57% of the overall tested residents and workers. Next slide. So I'm going to share a series of tables where on the right side we have the proportions of the demographic characteristic among everyone who was tested, and on the left side among those who are PCR positive. So what you can see, we had said before, about 50% people are male. Among the PCR positives, it was 75% are male. When we looked at ethnicity, 44% were in the Latinx category, Latino. 95% of all the PCR positives had an ethnicity of Latino. And if you look just above that row, you can see we tested, nearly 1,000 white or Caucasian people, and we did not find a single PCR positive. And these people are living in the same neighborhood and census tract. You can see that the remainder of the PCR positives were in the Asian Pacific Islander demographic. Next slide. So some other demographic categories, we can see that among the individuals who are PCR positive, they have a much higher proportion. They're in the lowest income tertile, which is shown here, 89%. And that's compared when you look at everybody, that tertile is about 39%. The PCR positives also were living in households of a much greater size than the overall residents and workers. We didn't see dramatic differences in this first pass in age differences, and we're really excited to look at certainly the antibody test for everybody, but particularly among the children. Next slide. So one of the questions that we addressed, we asked everybody about symptoms before we knew the results. And what we can see, which I did not find surprising, and which was that 53% of all our PCR positive participants reported absolutely no symptoms. Of the ones that reported symptoms, the most common ones that we saw were cough, muscle aches, and fever. Next slide. So our test to care intervention, the care part, we designed to augment the existing San Francisco DPH standard. We are very fortunate to have probably the strongest DPH in the entire United States. And I think, as you heard on Grand Rounds previously, that we have a robust and growing and innovative contact investigation and tracing unit that provides supportive services, access to hotels, and isolation facilities. What we wanted to look at in this community was, I would say, an augmented and perhaps more community-led and personalized approach from the ground up to those individuals who got, for most people, a shocking diagnosis of COVID. And we had a combination of a clinical response team, really from the long-standing tradition of patient-centered care that did the disclosure, daily medical assessments, and the linkage to care. We supplemented that with a new program designed by the community, which we call the Community Wellness Team. And this is really a field team where community members who live there and work there, they provided extra education about isolation and quarantine, all in a person's native language, and supportive services, hot food, grocery deliver, supplies by this team. Next slide. So we've reached 71 of the 74 PCR positives to date. We did find that only 30 of these had a primary care doctor. And so this CRT team is linking the remaining 41 people to care, and we're going to be working with these individuals until they really have their first appointment. And you can see just here, this is in the Brava Theater where we were stacking up all the slides, the supplies, isolation, and quarantine, education, masks, gloves, cleaning supplies that were provided to these households. Next slide. So here's a summary of these preliminary results. So over 2% of the persons tested that live or work in the Mission census tract are PCR positive 6 weeks into shelter in place. These COVID-19 infections are distributed unevenly within the community, and over half of these infections are asymptomatic. We also saw rather dramatically that low-wage Latinx community members who really from the nature of their job are unable to shelter in place and live in more high-density kind of settings are the most highly affected. Next slide. And then finally, I think when we all saw these results, I think most people were really a bit spellbound, and it was shocking. It was sobering. And I just want to, and it was exciting because all these people had come together, and here's pictures of all these people that worked together and many more that helped us. But this is something that John said at the end where, you know, what's going to happen to the community? And we immediately shared this information. And what he said, I think, really got us going, and the action plan of a healthier mission is a healthier San Francisco. I'll end my talk there.
Great, thank you, Diane. There we go. So before I bring Brian on, let me just throw a couple of quick questions at you that came in from the audience. Do we know of these asymptomatic people, whether they were pre-symptomatic and they ultimately went on to have symptoms, or was this just a single point in time?
What we know so far is that one of these patients, one of these participants subsequently went to be hospitalized. Right now, we are in the process of exactly answering that question. So after a certain period of time, to go back and ask everybody whether they were truly asymptomatic or they were pre-symptomatic and developed symptoms that didn't require hospitalization.
Right. And then do you have any sense of the types of occupations that folks were in, and whether that type of occupation was related to their risk of being infected?
Yeah, I mean, I think the folks that were PCR positive fell in a couple of different categories. One were those that were in service industries, such as the food and beverage industry. These people were out working during this time. Other were folks that were supporting all of us in things like janitorial services. There were also individuals whose work had stopped. Those would be individuals such as a hair salon or a nail salon where those had been shut down. So those were some of the main categories of individuals who were in the PCR positive category.
Got it. All right, let's bring Brian on, and Brian's going to tell us a little bit about the other portion of this study in Bolinas. So let's see where Brian is. There he is. All right, Brian, it's all yours.
Great. All right. Can you start the slide deck? Great. Thank you. So it's my pleasure to follow Diane and tell you about our similar efforts that we're performing doing community testing in Bolinas. Not too far away, but a world of difference in terms of how the community is set up. So this title slide also doubles as my acknowledgement slide, thanking a very large number of UCSF staff and community volunteers, community members, and agencies that came together to make this project happen over a period of just a few weeks ago. All right, next slide, please. So in Bolinas, the rationale for testing was very similar to the rationale for testing in admission. We really wanted to understand the transmission dynamics, in this case, in a rural community in the Bay Area, just a few weeks after shelter-in-place had started, and also arm people who may be infected with SARS-CoV-2 with the information that they are infected so they can take whatever steps necessary to help protect their families and community. Next slide, please. So we discussed a number of options in terms of how we were going to do the testing, and we settled on a drive-through design, really modeled on the UCSF drive-through testing, but we modified that design to increase throughput, given the number of people we wanted to test in a short period of time, and also to include antibody as well as PCR-based testing. Essentially, we took over a parking lot at a local park in Bolinas and set up a pop-up testing site accommodating 4 lanes of testing. I've gotten here on the left a schematic of how that was set up. Primarily, we had cars coming through, but also pedestrians, bicycles, and a really sweet Vespa from the 1960s. People were encouraged to register online in advance to help with the throughput, but also we allowed for on-site registration for those who did not have the ability or did not sign up online in advance. Once people came into the testing facility, they were registered, they were directed into a lane, and greeted by staff, and then had samples taken for PCR and antibodies, and then they were back in their car or bicycle or Vespa and on their way. Next slide, please. This is really new for us, so we started slowly. As you can see, this is the number of participants tested by hour each day of the 4 days of testing. And so we started slow intentionally, but by the last day, with continual quality improvement and figuring out how we could do this, we reached nearly 100 participants tested per hour with these 4 lanes. And the procedures and flow that we've optimized for this particular campaign, I think hopefully have some implications for many other places who are interested in doing similar testing on a large number of people in a short period of time in non-urban environments. I also want to highlight that Aisha is an ID fellow who really worked about 100 hours a day during this entire process, and that's a picture of her on the top right, filling in for an admin who went to lunch with a whole bunch of testing kits lined up in front of her and some testing going on in a car behind her. Next slide, please. So our results, relatively straightforward. We were able to test about 1,847 people over 4 days of testing. Over a quarter of these people had at least one symptom consistent with COVID-19 in the prior month, and 13% of people believe that they had had COVID in the past. Next slide, please. Despite this, not a single person of the more than 1,800 people we tested returned back with a positive PCR result for SARS-CoV-2. Next slide, please. So 0 sounds pretty simple, but what does 0 really mean? We've tested most of the community here and nobody was positive. So is this a completely clean bill of health for the entire community? The answer is a definite maybe. Based on the sensitivity of the test and the proportion of the population that we've sampled, we could still observe 0 cases even if there were a small handful of positives. But we are reassured to know that if there were any active cases in Bolinas at the time of testing, they were likely very few. On the right is a graph showing, given estimates of a true number of cases we may have observed, and the proportion of population that we've sampled, which we estimate is probably somewhere between 80 and 100%, what the probability would be of observing 0 cases. So you can see it could have easily been that we would have observed 0 cases if there were 1 or 2 cases, but if there were more than 4 or 5, it would have been very unlikely. And the statistical methods here actually come from veterinary methods used to test livestock for the absence of any disease in an entire population of animals. Next slide, please. Okay, so we don't have any antibody results yet, but for both the Mission and Bolinas studies, we are also performing antibody testing. And what will these data add? Unlike PCR, which really only tells us about active or very recent infection, antibodies will hopefully allow us to look into the past, gaining more information about infections that we may have missed. With this information, we can get a sense of cumulative infection rates, which will be much more sensitive than point prevalence. We can calculate attack rates, potentially in different demographic groups. We can detect any evidence of infections that have occurred prior to shelter in place. And in Bolinas in particular, we expect this number to be low, but of course, no lower than the PCR prevalence. One point I want to make is that all of the above estimates are really contingent on knowing how this antibody test will perform in the tested population. And a really important point that has not been receiving a lot of attention yet is that most infections are mild or asymptomatic, but the vast majority of tests that have been validated, antibody tests that have been validated, have been done so in hospitalized patients, many of whom have severe disease and potentially higher antibody titers. So those sensitivity measures are not necessarily directly relevant for the populations we're testing. Next slide, please. So this is my final slide. And I just wanted to point out that there are data in the literature, including the work that Alex Marson is going to talk about later, and potentially some data that Mike may tell you about, that indicate the sensitivity of some tests, as I said, might be quite lower in mild or asymptomatic cases than severe cases. So to see how much of an effect this would have on our population level estimates, Saki and Isabel, both colleagues with me in the division, performed a simple simulation over the last few days, estimating what is going on in the population and how that could be biased by the types of samples used for assay validation. So on the left is a estimate of the distribution of symptom severity in the population, with many of the cases being asymptomatic or mild. But we can imagine that an assay can be validated on a population that is similar to or quite distinct from this in terms of the spectrum of symptom severity. And on the right, you can see that by making estimates of sensitivity, including mild and asymptomatic cases of 80 and 60% respectively, the population metrics can be severely biased if we don't have these estimates for the antibody test that we're using. These data can easily be generated and used to correct for the sensitivity, but few companies have yet done so, or at least have made those results public. So it really highlights the need for more rigorous validation, which hopefully is a segue onto our next panel. That's my last slide. Thank you.
Great, Brian. Thank you. And that is a perfect segue as we begin diving deeper into antibodies. So let's bring John and Diane back as well. While they're coming on, Brian, someone asked about the Bolinas as a community. So can you describe the race, ethnicity? Is it a rural community? Is it represented? Does it feel like an island community in terms of its sort of interactions with other communities nearby?
Yeah, one of the residents actually described it as a cul-de-sac community because it's not really on a highway. It's a little bit off the highway. It's not that far. It takes about an hour to drive there from my house in the Sunset, but it's quite a world of difference away in terms of the feel. So it's a very interesting community. There's actually quite a bit more diversity in that community than I expected when we started. There are it has a reputation for being kind of an ultra wealthy community, and there are some people that are very rich, but the median income is actually lower than the national average. And there's quite a bit of diversity in the community. It was really interesting, actually. We did a town hall with the community, both before and after the study on Zoom to talk about the study and just getting to see all the people and then seeing them come through the testing, some of them in their fancy cars and some of them on their bicycles or walking up. You do get a sense of it being a really interesting community, a lot of artisans. They painted a lot of signs specifically for the testing. Yeah, I was only there for a few days, so it's hard to say I really knew the community, but it was definitely a very interesting flavor and quite a bit different than I expected.
Yeah, great. How do you talk about what from your perspective, what you and the community have learned from the results so far and how it will or has influenced policy? Can you hear me?
You broke up a little bit. Was that directed at?
It was a John. So.
Oh, okay. I'm sorry. I missed that part, Bob.
Yeah, sorry about that. So I don't know if you heard the question.
Vaguely. Can you repeat it?
All right, let's try it again. So from your perspective, and if you can speak for the community, so what are your takeaways from the results of these extraordinary different results and the striking results from the mission? And what does it say about what policies either should be enacted or maybe even have been enacted based on these results?
The differences were very stark and very apparent. And I think Dr. Havlir alluded to this earlier in that there was a bit of shock. I will say that given the numbers that we saw in general, and when the city released their demographic results, we saw that obviously Latinos were 25% of those who tested positive, but 15% of the population. But I will be honest, I was shocked myself when it was in the 95% of those all that tested, and that, 88% of those folks are all people that have to go out. Sorry, 90% of those folks have to go out and work. And I think what that did is it increased the reality that exists for us as a city that we must confront. And that is that poor folks of historically maybe redline communities that are at a disadvantage, that have to go out and work, are exposing themselves at a higher risk than those that have the privilege to stay home. And I think the city, for whatever this is worth, is now providing, as of Monday, the announcement came out, the Monday of our press conference, an hour before the announcement came out, that the city and county of San Francisco would begin to test essential workers, all essential workers, whether you're symptomatic or asymptomatic. I think that community would feel comfortable in claiming that as a victory, in that this was obviously raised to the level of no longer being able to say it's not a thing. And I think that's important to highlight. And secondarily, something that came through our community wellness team was understanding there were people that would tell us when we were knocking on doors that they are not able to take time off. Mm-hmm. If they get diagnosed positive with COVID but have no symptoms and are not sick, they risk not going to work and thus missing their bill payments and being wrecked financially. And that's something that we took into account. And what we tried to do is to mitigate, specifically for those people that cannot apply for state or federal funding, try to mitigate some of the cost for them. And what came out of that is Supervisor Ronan put forward legislation essentially covering those folks, once this is all done, up to $1,500 for the 2 weeks that they would have to stay home due to quarantine. And I would say that that is another very significant win, because the most marginalized folks that don't have a seat at the table are now given something that at least is a safeguard for them. And more importantly, for those of us that are interested in ourselves, is important in knowing that people can stay home and not continue the transmission. And I think those are all big wins for community and big wins for society. And I think that of this, more will come. It will continue to trickle out as the antibody results come back, and we can actually look at a holistic approach of what needs to be done.
Great. That's actually quite gratifying to hear that those kinds of actions have been taken. We have a couple of minutes, maybe one for Brian and one for Diane to close. Brian, sort of in terms of sampling strategies, we hear about other studies that sample by asking people to come in through Facebook ads or other ways. What do you see as are there advantages to the way that you guys chose to do your studies?
Well, certainly there's an advantage in trying to capture as many people as possible, because you get hopefully the most representative set. If you wanted to do this just for surveillance, however, I don't think this would be the most efficient way to sample. I think you would probably sample more sparsely in more communities and get a better sense. But because that was not really the primary goal here, the primary goal was to turn these results into action, then you really do need to get a much more dense capture, because if you sample 10% of a population, even if you capture some cases, you're not going to change transmission. So I think it really depends on your goal.
Okay. Diane, you've worked in HIV for a long time. What were the lessons from HIV that helped inform your work here, and both in terms of the way you did the studies and also the policy implications? You're on mute.
Sorry. I think the San Francisco model of putting patients first with the disease and having a partnership between the community, the scientific community and academics, and the policymakers is the most effective and efficient way to combat an epidemic. And that's the principle. That's what San Francisco has done. And that's what needs to continue to happen in COVID.
Yeah, no, it's striking, having lived through the early years of HIV here and how absolutely essential the partnership was in getting stuff done. It's clear that that has come through here. And congratulations to all of you on this work. It really is important and influencing not only local policy, but influencing national policy as well. So thank you all for being part of this. And we're going to switch to the next segment. I think Brian gave a good introduction about why antibody testing is complicated, and we're all learning about it as we go along. So we're running a couple of minutes late, so we may go over maybe to 1:35. We'll make sure we give this enough time. First speaker is Michael Bush, who's professor of laboratory medicine at UCSF and also directs and is senior vice president for research and scientific programs at Vitalant, which is one of the nation's largest not-for-profit community blood service providers. There he directs research programs focused on blood safety as well as infectious diseases, and has been central to some of the work we've been doing in trying to understand antibody testing. So Michael will go first, and then Alex will follow him. Thanks, Mike.
Yeah, thank you, Bob. Can you hear me okay?
Perfect.
Great. Yeah, so I just put at the bottom here the brief notes that Bob sent me over the weekend of what he wanted me to address: the applications, limitations, quote, abuses of tests for serology, how these tests can be interpreted at individual scientific policy levels, and then seroprevalence studies, which we've heard some examples of, and I'll be focused on. Next slide, please. And antibody tests for all agents, but SARS-CoV-2 in particular, have many potential applications. They can be used in acute infection diagnosis as an adjunct to molecular testing. They can be used to test for recently acquired infections in healthcare workers, first responders, the back to work concept, to attempt to stage when people became infected by looking at the dynamics of immunity over time. There's a lot of work going on now to qualify donors to give convalescent plasma for transfusions, as well as hyperimmune globulin production. Serosurveillance, a huge area now of both in focus populations of healthcare workers or first responders, but now we're beginning to see both regional, state, and national serosurveillance studies, which we'll talk about. It's also important to understand the role of antibodies over time in terms of durability of immunity through longitudinal characterization of the immune responses over time, and the correlations with respect to protection from reinfections. And actually, antibodies can be a good sensor for reinfections because antibodies boost when you get reinfected. So by tracking antibodies in large populations over time, you can actually gain evidence around rates of reinfection. And then as vaccines become available, we obviously need to have tools to measure the vaccine-induced response as well as the effects of infection in vaccinated people. Next slide. Just to point out that these different use cases require different types of assays, ranging from point-of-care assays to lab-based screening tests. The antigen represented in the assays can either be internal nuclear capsid or spike-based envelope assays, which are more relevant to vaccine protection. And then we need confirmation assays and characterization assays, and there's a number of novel techniques, predominantly microarray-based, that are useful here. And then to really assess the efficacy of these antibodies with respect to protection, we need assays that can quantify the neutralization potential of these tests. And these range from plaque reduction neutralization tests to reporter viral particle neutralization assays. And then there are new reporter binding domain spike assays that are being developed as potential higher throughput surrogates for neutralizing. Next slide. So this, I'm not going to go through this, but I just wanted to point out that there was just in the last week a JAMA review on interpretation of diagnostic tests, and this kind of classic figure, very similar to historical figures on HIV, hepatitis viruses, that point out that there is a eclipse period following exposure before any test is positive. And then in the earliest stages, molecular testing, predominantly swab-based, is the approach for diagnosis, and then antibodies become relevant later and potentially allow you to not only detect exposure, but to stage infections, for example, by detecting IgM. Next slide. Just our focus is on lab-based assays, and we'll hear a little bit later from Alex about the performance of point-of-care tests. But given the scale of studies that we do in the blood bank context and the large surveys we're involved with, we're really focused on the performance of really high-quality manufacturer lab-based assays. And you can see here a number of these have been approved, gotten emergency use authorization from the FDA. They range from antigens that include the spike versus the nucleic capsid versus combinations. And the format of the assays range from IgG, IgM, to what are called total Ig assays. So in the next slides, I'll talk about a couple of these that are ones that we focused on both at our institute and at UCSF. So the next slide, please. So this is one of these lab-based assays. It's the ortho-vitreous anti-SARS-CoV-2 total Ig. So this test is a very high throughput. We have large numbers of these platforms, both at our testing division and at our center in San Francisco. These antigen sandwich-based assays can detect IgM, IgA, and IgG with very high sensitivity and specificity. So you can see at the bottom the very wide distribution between a negative population and the cutoff. And on the right, you can see that individuals who had swab-based confirmed infections, when plotted relative to time from symptom onset, the vast majority are reactive, and of those who are tested greater than a week or so out from symptom onset, all of them are reactive. Those that are not were neutralization negative. So these were people who were in the pre-seroconversion incubation period. Next slide. This is data from a new paper by Diana Ng and Charles Chu led these analysis, and we've been involved in this collaboration just to show at UCSF there's been outstanding work, again led by Charles, to look at the dynamics of seroconversion in symptomatic patients, looking at the evolution of IgG antibody. This is the Abbott test, and the neutralizing antibodies really maturing quite briskly following exposure, with again increasing rates of antibody positivity relative to time since symptom onset, as mentioned earlier. The next slide. This just shows one example. This is an assay that we have running at our institute. Graham Simmons has developed it. So instead of doing live virus neutralization tests, which are expensive, take a week, and have significant risk of lab infection, we've developed, Graham's team has developed, and we have high throughput capacity to use reporter virus neutralization technologies. These employ a pseudovirus that's been engineered to express the SARS-CoV-2 spike protein, and then you incubate the serial dilutions of a patient sample with this virus prior to inoculating a target cell line that has a colorimetric readout. And you can see on the lower left that these assays correlate well with live virus neutralization, and then on the right, just examples of neutralization titration data coming from analyses of convalescent plasma from donors coming in to give plasma for therapeutic use. Next slide. Another tool we use a lot is a antibody array that was developed by colleagues at UC Irvine, Phil Felgner's group, which has a large number of antigens, not only to SARS-CoV-2, but also SARS-1, MERS, and many other common acute respiratory viruses, common coronaviruses, etc. So this allows us to profile the antibody reactivity at the same time on a single array analysis, not only to the antigens represented by SARS-CoV-2, but across the spectrum of other respiratory antigens. And particularly of interest is the question of the impact of prior immunity to other coronaviruses on both the antibody dynamics and disease progression in SARS-CoV-2. Next slide. We have a recently funded, very large study that I just want to highlight that is funded by the CDC. It has three aims. One is to really do a very rigorous evaluation of a large number of these lab-based assays. But most important is we'll be launching then, have already launched actually, a study that will capture 1,000 samples from each of 25 metropolitan regions throughout the US, from blood donations with all the demographic information. This will be done monthly for 12 months and then at 18 months. And I'll show a slide on that in a moment. And then in addition, we'll be following a large group of these convalescent plasma donors for 18 months to monitor for the waning of immunity over time and characterize that both with respect to individual protection from reinfection, but also herd immunity. Next slide. Just as a map of the sites, it includes Alaska, Hawaii, and many regions around the US. This is, again, a collaboration between the NIH REDS program and the CDC. Next slide. Just some early data from that, just a peek at some data. This is New York City, looking at the left at 500 samples collected from blood donors, and you can see there's 7 strongly reactive, all confirmed. On the right are parallel data from convalescent plasma donors. So these are donors coming in to donate after they were sick and recovered. And you can see, very high level distribution of reactivity corroborated by neutralization. But there are some people who are negative. You can see below that cutoff. And most of these were misclassified. They were never infected in the first place. So it just compares the distribution of antibody in people who've recovered versus asymptomatics who were detected through serosurveillance, really to address the point that Brian made about the need to understand antibody reactivity in symptomatic recovered people versus asymptomatics. Next slide. This is again from Charles's work, just looking at the Bay Area. So this is brand new data that's just being submitted. It's showing data on symptomatic cases, but most importantly is serosurveillance data, both from UCSF Hospital and local blood donors, showing extremely low rates in San Francisco of antibody positivity as we begin to apply good tools, serologic tools, to estimate incidence. Next slide. Just correlating the antibody levels with neutralization titers. So you can look at the reactivity on these high throughput screening assays relative to the neutralization efficiency of these virus based on neutralization assays, and a very strong correlation overall. And certainly we're using this as a tool to qualify donations for convalescent plasma transfusion, but not one-on-one. So people can have low binding and high neuts, vice versa. Next slide. Just finally, the data slide to point out that we are following large numbers of infected people, both patients and donors who are coming back to give convalescent plasma, with the major goal of characterizing the persistence of immunity over time, which is so important to understand. As immunity wanes, as it does in common coronaviruses, we need to understand that pattern of waning reactivity, both overall and neutralization specific, and the risk of reinfection. And I think the last slide is just a summary of the limitations. Next slide, please. Yeah, so just to point out the concerns, as Bob was kind of raising in his caveat here at the beginning, false positive results, a major problem. We saw data, for example, from that Santa Clara Stanford study that I believe was all false positive results. They were using a rapid test that had a 1.5% false positive rate, and they detected a 1.5% reactivity rate. So really using specific assays, and to my mind, lab-based assays to the extent possible with confirmation algorithms. You cannot diagnose people who haven't seroconverted yet, so this obviously applies to symptomatic people shortly after infection, but there may be some asymptomatic infections that don't seroconvert, so we're trying to better understand that. The dynamics of antibody seroconversion varies based on development of symptoms and possibly prior antibody responses. And there are unknown relationships between antibody persistence and protective immunity that need to be studied. And these responses wane, so we really need to characterize the immune responses, and there may be a role for vaccination, not only for prophylaxis, but for boosting of immunity. And then the role of vaccines is obviously going to shake everything up big time. As we vaccinate populations, we need to be able to differentiate vaccine-induced responses with breakthrough infections. So we need new tools and assays to do this. And then finally, the virus is evolving. Although we thought this was a very stable virus, recent evidence supports evolution of mutations that both reduce and increase pathogenicity. And we need to be monitoring the evolution of the virus to be sure that our assays are accurate for diagnosis and surveillance. Thank you.
Thank you, Mike. Before I bring on Alex, I have to, that's too burning a question to wait on. So if I went in to donate blood today, would you be testing me for virus? And if so, is there a worry that the disease is transmitted through the blood?
Yeah, thanks, Bob. No, there's never been a transfusion transmission case of any of these respiratory viruses. We've done studies on SARS-1 and MERS and H1N1. We are doing large-scale studies to look for evidence of RNA-emia, we call it. We don't call it viremia because of lack of infectivity. We're also doing very careful studies with the Davis colleagues on macaque systems to look at transfusion transmission questions. So there is no screening currently. Stanford is screening of note because they chose to, despite the FDA's guidance against doing so for RNA and plasma. And we're not doing serologic screening other than in selected populations of donors coming back for convalescent donations.
Right, that part's comforting to hear. All right, let's bring on Alex. So Alex Marson is Associate Professor of Medicine in our Division of Infectious Diseases and the Department of Microbiology and Immunology. He's a world expert on genomic engineering and use of CRISPR and other novel technologies to figure out important questions around genetics, infectious disease, and immunology. He'll be talking about a major study that he and colleagues just completed on various antibody studies that received worldwide attention. Alex is also the scientific director of the UCSF UC Berkeley Innovative Genomics Institute. And I guess about 5 days ago is now the new director of the Gladstone UCSF Institute of Genomic Immunology, which is very exciting. So Alex, welcome and go for it.
Well, thank you for having me. This is obviously a departure from what my lab normally does, but we benefited from a wonderful collaborative team, including Jeff Whitman from the lab medicine department, Patrick Sue at Berkeley, Karen Byrne from Epi and Biostats, and many volunteers from my lab and others who really raced into this problem to see if we could come up with some basic information about lab performance characteristics of antibody tests that were starting to flood the market, that we started hearing about early in the shelter in place. This is actually a picture of a rapid diagnostic test for antibodies that was distributed widely. This picture was actually sent to me by a friend who you can see was trying to get blood on the spot and see if she had antibodies. And she asked me what this test meant. This was just as we were starting these results, and really motivated me to be able to get some basic information about whether tests like this may provide any useful information about who has been infected with the SARS-CoV-2 virus. Next slide. On the next slide, I will just show my disclosures briefly. This work was funded by a gift from Anthem, from the Chan Zuckerberg Biohub, and from some donations from the vendors and some philanthropists. This is not peer-reviewed yet, but we have been sharing this work early in the spirit of getting this data out there to the scientific and medical community, not to inform clinical decisions, but just to get basic data out, and we continue to analyze the data. Next slide. So as you've heard from previous speakers, and Mike touched on this, diagnostic tests for antibodies come in at least 2 different flavors: lab-based tests and rapid diagnostics that could be potentially employed as point-of-care tests. The lab-based tests that are prominently used include ELISAs, a picture of which is represented on the left. The rapid diagnostic tests, also known as lateral flow assays or LFAs, are shown on the right. And one thing that was interesting to me that I learned was that although these in many cases are marketed as either having a positive or negative, you can see shown here as a schematic, there actually are some ambiguities, and there does seem to be a range of intensity of the bands. The top band is the control, the lower band is the intensity. And so what we did in our study was, rather than call them positive or negative, we tried to capture scientifically the ambiguity and the gradations by scaling them all on a scale from 0 to 6, with 0 being absent, 6 being positive, but 1 and 2 being very faint bands that are just barely visible to the naked eye. And that's not necessarily meant to capture how these would actually be implemented in practice, but to give more information about how these tests would actually appear to a subjective reader. Next slide. We started just reaching out to dozens of different vendors that were becoming available, and early on we got sent a number of different tests in sufficient quantities to demo. We demoed 10 different lateral flow assays. We adapted an ELISA that had originally been developed at Mount Sinai with the help of Jason's sister's lab here, and also used one commercial ELISA kit to give us some comparators between the lateral flow assays and ELISAs. Here's how we actually did the testing. This was a set of specimens that were collected. Importantly, we collected, both from the UC system and from Zuckerberg San Francisco General Hospital, a collection of blood samples. These were from individuals that tested positive by RT-PCR. We didn't know when they would actually seroconvert, so we tried to capture them at different windows after the onset of their symptoms. We had 79 different samples from 79 different individuals, but ended up with 128 different samples, as some people had specimens that were included from multiple buckets after the onset of their symptoms. Another critical set of blood specimens came from before the outbreak of coronavirus. This is going back to 2018 and before, so that we could confidently say that these were negatives, and this allowed us to really assess specificity. And then we also had a small set of blood samples from recent patients who came in and underwent assessments, either with PCR for SARS-CoV-2 and were found to be negative, or tested with a respiratory viral pathogen panel and were found to be positive for another pathogen. Next slide. So on this is what happens, I guess, if you have people who normally do genomics, dabbling in lab medicine. We chose to represent our findings in the form of a heat map. This was, I hope, informative. It was informative to us. Each row here is a different patient specimen, and you can see we've grouped them by different times after the onset of symptoms. The color of each box shows how each different test, shown as a different column, performs on that particular specimen. Darker blues are the higher intensity bands on the lateral flow assays. Darker purples are higher titers on the ELISA. And you can see that generally the pattern that we saw was that we are able to detect antibodies appearing in most of these specimens, especially at the later time point. But as you've heard from previous speakers, there is a time period where there's a range of when people will seroconvert. So we did see some heterogeneity, but most samples could be detected, and we saw some variation from test to test. I will say that there were a couple of specimens that remained seronegative even at later time points, and it's possible that those are due to immune compromise. One of the ones that stayed negative by most tests at the 16 to 20 day window, for example, was from a renal transplant patient on an immunosuppressive regimen. So there may be some actual true negatives that are, and so these do not necessarily tell us false negatives, but they do tell us about how each test was able to comparatively detect antibodies in these specimens. Next slide. So we did see a range in the performance of ability to detect antibodies. This is shown for all the lateral flow assays and their ability to detect either IgM or IgG at different time points after the onset of symptoms. Next slide. As you heard from Mike Bush, I think one of the critical things, especially if we're thinking about seroprevalence studies, but also thinking about whether we can tell people confidently that they have been previously infected, is to have a test that has high specificity. So this was how the test performed on the true negative specimens drawn going back well before the beginning of this pandemic outbreak. And you can see that although most of these were negative, we do see some tests picking up false positives in these, and we're able to compute specificity as based on the number of true negatives and false positives, as you can see here. There was a range again of specificities shown on the next slide. And so you can see that we saw a range from about 84% to 100% specificity if we combine the measurements of IgM and IgG. And so this really is an important measure of heterogeneity. There's some overlap in the 95% confidence intervals, but it does seem that some tests appeared more reliable than others in giving true positives and true negatives. Next slide. One thing we noticed was that many of the false positives were actually low intensity bands. So you can see here in green are the different time points of the true positive, of the positive specimens at different points after onset of symptoms. They tend to be, especially at the later time points, relatively high intensity bands on the lateral flow assays, with many of them in the 6 range. You can see in gray are the pre-COVID-19 samples, and many of them are negative, but the ones that are positive, many of them are 1s and 2s in this indeterminate range or low intensity range. And so we found that you could actually potentially shift the specificity based on how you train readers to interpret those low intensity bands. That was something that would require careful implementation strategies if these are actually going to be rolled out for use in point of care settings. One strategy would be to use electronic devices or cell phone measurements. And there's some discussions underway about potentially coming up with a more informed way of interpreting these results. We did report some results in collaboration with colleagues at MGH, and they tested one of these lateral flow assays. They reported higher specificity for the biomedomics than we did. And there's some differences in their study, but one notable thing was they had a more stringent cutoff of band intensity to call positives. And we think that that's one way to dial up specificity of these tests. Next slide. Another measurement that we care about is how these perform over in different patient populations. This was alluded to by Brian Greenhouse. One concern is that these may do a better job of detecting antibodies in patients with more severe clinical course. We found that our study was heavily skewed towards patients who were inpatients, either admitted to the general floors or to the ICU. So we'd had low representation of ambulatory patients at the later time points. Although it's hard to, the numbers were limited, which limits our statistical confidence, there did seem to be a trend towards lower levels of antibodies in the ambulatory patients. And so we do think that this warrants further study to assess whether these test performance characteristics are in fact generalizable to less sick individuals, especially if we think about expanding them to asymptomatic population and to inform true seroprevalence studies in the future. Next slide. So what are the lessons that we took away from this? What I would say is that first, let me talk about the limitations. First, that we at the later time points, we have fewer ambulatory patients, And so we're able to say less about how this performs on ambulatory patients, and we're not able to say anything about asymptomatic patients or patients who are convalescent at later time points. We really need that information. Also, although these were lateral flow assays that are in fact designed to be done on finger prick blood or capillary blood, we were using venipuncture, serum, or plasma, and further studies would really be needed to see that these could truly be done on capillary blood. And one important caveat that we really need to emphasize is that none of this tells us about whether these studies would have any information about who would be protected from future infection. This is really the first set of information to give us information about how reliable they are to tell us whether antibodies are present or absent. Further studies are absolutely critical to say whether the presence of antibodies in fact correlate with any protection from future infection. And as far as I can tell, that can really only be done in epidemiological studies of people with and without antibodies, who are especially people who are high risk for future infections, to see whether antibodies actually confer protection. And that might not be because the antibodies themselves are conferring protection, but they may be a surrogate marker for protection. Next slide. This is my last slide of I seem to have skipped over the conclusion, but the conclusions were that we really saw heterogeneous results. We think that this provides basically a bare minimum information to start thinking about test performance characteristics, and more data is really essential. I think that this is true for any lab-based diagnostic, but here there was given the urgency of the situation, there was a flood of tests that became available before the test performance characteristics were, and we're just racing along with many others to perform that test validation, and hopefully say when and how, if at all, these tests could be deployed for future use. I'll just end there, but I want to really thank a lot of people who I mentioned as collaborators, but many, many others from multiple departments across UCSF, Berkeley, Chan Zuckerberg Biohub, Innovative Genomics Institute, and many volunteers who really raced out, put themselves potentially at some risk, but did so to try to help out in this crisis. So I want to thank the many volunteers who contributed to this work.
Great, thank you, Alex. And so we'll go another 9 minutes. So folks, bear with us. And there are too many important questions that are coming up from the questions. So maybe Alex, first, did the FDA make a bad decision by being so liberal in approving all of these tests as you come and look at the test characteristics?
I think I'm not going to comment on FDA decisions. I think all of us I think the broader context is that there's an urgency to come up with tests, and I think that there's a balancing of how do we make tests available, but not make them available more quickly than the necessary data is required to actually make their interpretation useful and not to create more confusion. I think the FDA has continued to refine their guidelines and has come up with a more refined strategy now for making sure that that test validation data is available at least shortly after these tests become marketed to individuals.
Right, I don't know, there's, okay. Given the challenges with test characteristics and a number of the tests, maybe for both of you, what would a reasonable practical strategy be? Should one have a second different test to confirm a first, or you just look for the best of the tests if you're going to use testing? And I guess some of this depends on what the stakes are. What are you using the test for? But maybe start with Alex, and then I'd love to hear Mike's thought on that.
So I will say that, as this progresses, we're seeing that some of the commercial platforms, especially the lab-based diagnostics, do seem to have better test characteristics than some of the earlier results that were reported. So I think that there is actually progress. We do think that having a diversified set of tests that are available is actually probably important, especially with the risk of supply chain interruptions. And there may be some benefits, which we're just still thinking about having multiple settings where tests could be deployed. If some of these lab-based, some of the rapid point-of-care tests are to be deployed, one strategy would be to potentially use combinations, either potentially starting with a high sensitivity test and then doing a confirmatory test in the lab, or doing a combination of two different tests. And we're starting to look now at how combined test information may actually improve and enhance test performance characteristics.
Got it. Mike, do you want to weigh in on that?
Yeah, I agree. Certainly, to the extent the point of care assays are fielded, just like with HIV in Africa, et cetera, serial use of two tests is, I think, very important to confirm. Certainly in the blood bank setting where we're dealing with low prevalence, low incidence infections, and in general, infectious diagnostics, the principle of a testing algorithm, that you use an initial screening test, and generally we would even repeat that test and only consider samples reactive, they're repeat reactive, and then we reflex to a confirmatory test. And that's certainly the way we are employing these tests in our both serosurveillance studies as well as in the convalescent plasma qualification.
Got it. And Alex said something pretty provocative, which is that we're only going to know about whether antibodies are helpful in preventing future infections through epidemiologic studies of following people. Is that right from your perspective, or are there things that one could possibly learn from the laboratory studies that might help us figure this out? It seems it is the central question in many ways as in trying to get us out of this mess. Go ahead, Mike. How do you think about
for me?
that? Yeah.
Well, I'll take that. That's critical. You know, and again, there's several ways you can approach assessment of persistence of immunity from reinfection. Certainly, animal studies, macaque model studies are in progress that are looking at that question. You know, certainly in humans and common cold viruses, there was actually re-challenge of people as immunity waned, and those studies were quite informative, showing that the common cold coronaviruses, people could get infected with the same virus 1 to 2 years later as immunity waned. In the very large scale programs, we're designing studies to follow literally thousands of convalescent plasma donors over time, over years, and using the immune response as an indicator of reacquisition. So a boosting of antibodies against SARS-CoV-2 could be the best way to ask whether there's significant rates of reinfection in communities that are experiencing additional recurrent outbreaks.
And Alex, Mike made the comment that probably the first study that taught us that this whole issue of antibody testing is a little bit fraught was the Santa Clara study with a much higher prevalence rate than anybody expected. And Mike's point was that he thinks many of, if not most of, or all of the positive or false positives. Based on your understanding now from your studies, how do you interpret those results?
I think Mike's point is generally my thinking that we really have to interpret the results of any large study based on the prevalence and generally the pretest probability of any individual actually being positive. And if the overall prevalence is low or the pretest probability about the population that you're testing on is low and you have a considerable false positives, you're really going to muddy the picture, and many of the positives you'll detect will be the false positives. So I think
as Brian goes back to Bolinas and all of those, no one was positive on the PCR. Based on your understanding of the tests now, are there any tests that are good enough that if someone's a positive, you would believe it?
I think we're starting to see that there were a handful of tests that had performance in the 99 to greater range. It's hard to know if there's a real difference between the 99% and 100% on a sample set of 108 negatives that we assessed. So I think we really need a larger set of negatives to really start reliably saying exactly how many false positives we'll expect in a large study like that. But I think if we have some measurements like that, we'll be more informed in making the appropriate adjustments as we contemplate what the seroprevalence studies are really telling us.
And I see Brian just pinged us on the chat that we're going to use at least 2 orthogonal tests for positive, especially in Bolinas. So I guess that's the point, that in a very low prevalence population, you really got to be sure that a positive is not a false positive.
I think another question that's worth considering is how these will be interpreted in clinical settings, not just for seroprevalence, and is there a role in them in diagnostic algorithms? We did find at least one patient who tested RT positive negative, but was positive for by multiple different assays for antibodies against SARS-CoV-2, suggesting that this may have been a case for someone who was missed on the molecular diagnostics, maybe presented late in the course. This was someone in her 90s who presented with a clinical picture, including ground glass opacities on a CT scan that would potentially be consistent with infection, but it was actually diagnosed based on the RT PCR negative and other ancillary testing with a presumed diagnosis of a urinary tract infection. So I think that there may be some role for complementing the molecular diagnostics, the viral testing, with antibody testing, but we really have to think carefully about having a high enough clinical suspicion and then matching that with a serological testing that actually is informative. It may be late and in the course by that time, and it may no longer be infective, and it may not alter clinical management, but it may actually inform contact tracing or some late decisions about how we manage these patients.
All right, maybe my last question is, actually for both of you, but Mike first, what's your gut tell you in terms of the the level of immunity that the patient who's recovered from COVID has, and how long it will last? You've studied these kinds of infections for a long time. Obviously, this is novel, but you know more about it than any of us. So what do you think we're going to find?
Well, I think the large majority of people who were sick, certainly, and even hopefully a high proportion who had asymptomatic mild illness, do develop neutralizing antibodies and will be protected from reinfection from 1 to 2 years. We'll know soon whether their plasma is efficacious in treating people. That'll be informative to the question. But that immunity will wane. And so absent vaccines to boost immunity and vaccines to induce immunity, I think we're seeing very low infection rates in the US, and the concept of herd immunity, et cetera, is really, we're a long ways off from being protected from this virus.
Yeah. Alex, any final thoughts on that?
Well, I certainly defer to Mike's wisdom on that. And I hope he's right that that there will be natural immunity. I think if that's not the case, I think the vaccine will be harder to develop. But I think that there's some reason for optimism. We just really need the studies to tell us exactly who's protected and for how long. And
yeah, I've just been. I mean, just as a clinical observation, I don't know this, the science here well enough, but you would think that if the antibodies were not protected, we would be seeing a lot of people in New York hospitals with second infections now. It's sort of hard to kind of come up with a scenario that says the antibodies don't work, and yet the hospital's not overrun with people who were infected in March and got better, and now we're back with their second infection. Does that make sense to you, Mike or Alex? Or
well, just one comment on that. Reinfections in common cold exposures, they tend to be subclinical. So even though people may get reinfected, they'll boost their antibodies, they'll have mild symptoms. But I agree with you. I think protection is going to be induced, and it will last for some period of time. And even if it wanes, I think there'll be immunity to kick back in and hopefully suppress the infectivity and reduce the symptom consequences.
I hope you're right, because otherwise I find it difficult to sleep at night. But
say one last thing. I would just say I think that I just hope we can come together as a scientific community and capture that data. I think that as more and more people are getting antibody testing, if we aggregate the data properly and really do the epidemiology, I hope that we can get that information quickly, because people are really urgently waiting for that information, and we haven't been able to give clear guidance to the general population about what these antibodies will actually mean.
Yes, well, that's a nice way to end it, although it strikes me just that the level of scientific understanding and progress we've made in 3 months is extraordinary. And
I agree with that.
Part of it is what both of you have been doing, and all of our colleagues. So let me thank you, and just close by thanking all of our speakers for a wonderful discussion. As always, the video will be posted on YouTube later tonight. I'll disseminate the link on Twitter, and then we'll send it out through more traditional channels. Let me thank our crack production team. You see them listed here, who put this thing together every week, and we'll see you back here next Thursday. Still trying to figure out which things to cover. Probably we will look at some of the emerging problems with children and maybe in older populations as well. And we'll continue doing this as long as there's new information to cover, and I'm hoping we'll be able to stop it sooner rather than later, but certainly there's still a lot going on. So thank you all for joining us, and be well.